Hello and welcome to my channel. This lecture we're going to discuss the large intestine. The large intestine, of course, the small intestine ends at the ileum, ileocecal junction. So it starts from the ileocecal junction till the anus in the perineum. It's about 1.5 meters long, and it's wider than the wider at the cecum and narrows towards the rectum. The appendages called the appendices epiploicae increase in number as you go distally through the colon. Now, first, let's describe the course of the colon. It starts by the cecum in the right iliac fossa. Then the ascending colon, it goes up till the right colic flexure behind the liver and on the right kidney and the right kidney lower pole, and then after the right colic flexure the transverse colon starts and we cross the abdomen transversely till we reach the left colic flexure. It should be drawn here at much higher level than the right one because it's suspended by a ligament called the phrenico-colic ligament, as well as the left colon, which is the descending colon, is longer than the right one. Anyway, so at the left colic flexure, not on the lower pole of the left kidney, but beside the kidney, at the left side of the kidney, and then the descending colon descends across the hypochondrium to left lumbar region to left iliac fossa, and as you go down, it shifts medially to form the sigmoid colon, which is called the pelvic colon, and then the sigmoid colon has a rather S-shaped course. It may reach to the right pelvic wall, but anyway, it curves, goes laterally, goes to the right side, and then back to the midline where it ends level with S3 as it becomes the rectum. So it from the right iliac fossa through the right lumbar, right hypochondriac, across the abdomen to the left hypochondrium, left lumbar, iliac, and then to the pelvis as it crosses the pelvic brim. It has the intestine usually has two layers of muscles, inner circular and outer longitudinal. The outer longitudinal of the colon shrinks on itself to form bands of tinea coli. But as you go distally, these tinea coli increase in width and becomes a full layer around the rectum as the outer longitudinal layer of the rectum. Now, the differences between the large intestine and the small intestine, of course, the large intestine is wider in caliber and shorter in length. The ascending colon, descending colon are fixed to the posterior abdominal wall. The transverse and sigmoid have mesenteries. Of course, the small intestine, all of it except for the duodenum, has a mesentery. The characteristic of the colon is what you see here, the hostrations. See the hostrations, the grooves or dents between the saculations. These are saculations separated by hostrations. This is because the tinea coli is shorter than the colon itself, so the colon, like it's wrinkled upon itself to form the hostrations and the saculations. Also, a major difference between the large intestine and the small intestine is the appendices epiploicae, which are peritoneal appendices full of fat and guards an opening through which the vessel penetrates the wall to supply. the vessel supply of the colon. And the appendices epiploicae increase in number as you go distally. It almost covers the sigmoid colon here. When you see it in real life, it's a piece of intestine that's almost totally covered by appendices epiploicae. Okay, this is the major differences between the large intestine and the small intestine. So let's study the different parts of the colon. We'll start with the cecum. This is the cecum. Cecum means a cul-de-sac. A cul-de-sac marks the beginning of the ascending colon. It rests on the iliacus with the lateral femoral cutaneous nerve and ilioinguinal nerve separating it from the iliacus muscle. When we say, when we mention a nerve as a relationship to an organ, always put in mind the referred pain. Something wrong in the cecum may express itself by a referred pain along the lateral femoral cutaneous nerve, like the lateral part of aspect of the thigh, for example, pain shooting, radiating to the lateral aspect of thigh. Why? Because it's involved in the condition that the cecum is passing through. And it rests also on the psoas major muscle, separated from it by the retrocecal recess and appendix. Anteriorly to the cecum is the anterior abdominal wall and the lateral half of the inguinal ligament, the greater omentum, and of course coils of small intestine that fill the area, jejunum and ileum. Here, of course, coils of ileum. Because it partially protrudes in the peritoneum, so that it has a recess behind it, so it's slightly mobile, and this is also makes sense, like the first part of the duodenum, which is mobile like the stomach, not so as not to get sudden abrupt changes in the environment the chyme is passing through inside the intestine, and to release the tension on the cecum. So it's slightly mobile because of it slightly protrudes in the peritoneum to form the retrocecal recess behind it. A criteria of the surgeons used to trace the appendix in appendectomies. If you're lost in the field and you can't find the appendix because of its, variable position, as we will study now, just follow the tinea coli on the anterior surface and posterior surface of the cecum. You will find out that they converge towards the base of the appendix. They converge towards the base of the appendix. This is the appendix here, and this is the mesoappendix. See, this is the appendix and how the tinea converge to the base of the appendix. You will find this on the anterior surface and the posterior surface, or posteromedial and posterolateral surfaces as well. They all converge to the base of the appendix, and this is a surgical landmark or a surgical way to find the appendix if you can't find it normally. Okay, these tinea coli, as we said, as I said, as you go distal, they broaden, the bands broaden, get wider, and widest at the sigmoid colon, and of course, it completely covers the intestine at the rectum to form the outer longitudinal layer of the rectum. The ileocecal valve, see, it's in the posteromedial surface of the cecum. It's horizontal. It has upper and lower flaps. The anterior end is wider, little wider than the posterior end. See, it's like a horizontal tear drop. Upper and lower flaps of the ileocecal valve. It's kept tonically closed by the sympathetic supply, and its major function is to prevent regurg of stools or chyme back to the small intestine. So it's tonically closed, only opens when the chyme reaches the ileocecal valve, and it starts to pour into the cecum. Now, there's a surface landmark for the ileocecal valve. It's at a point where the midclavicular line transects the transtubercular line. So remember, it's not the McBurney's point. The McBurney's point marks the base of the appendix, but a point that at the intersection between the midclavicular line and the transtubercular line marks the ileocecal valve. Remember this as an important surface anatomy. The peritoneum at the ileocecal junction makes folds, like here, as you can see here, the superior ileocecal fold, the inferior ileocecal fold. The superior ileocecal fold has the terminal branches of the superior mesenteric, the ileal branches, but the inferior ileocecal fold has nothing in it. And this is a multiple choice question, has nothing in it, the inferior one. And of course, if there is a fold, so there should be a recess in most cases, especially if the fold is big. So it forms a recess underneath. This is the inferior ileocecal recess. This is the superior ileocecal recess. And as I told you before, the cecum partially protruded in the peritoneum. So it made a recess behind it, or multiple recesses besides it. This is called the cecal retrocecal recesses, and they are responsible for the mobility of this part of the intestine, the cecum. The vermiform appendix, as you can see here and here, this is the vermiform appendix. It varies in the posteromedial surface, opens in the posteromedial surface of the cecum. It varies in length among individuals. It's simply a tube filled with lymphoid follicles and has a narrow opening that opens into the cecum. This opening may get occluded by a vegetable seed or anything. So the appendix goes into a vicious circle of obstruction, edema, compression of the venous drainage, and more edema and more obstruction. And this is the case of appendicitis. If left untreated, it endangers life unless the body controls this inflammation by forming adhesions around it by the greater omentum. And in this case, it will be turned into an appendicular abscess. It has a completely different surgical approach. Positions of the appendix vary from retrocecal, pelvic, subcecal, in front or behind ileum, and recorded a case of subhepatic in which the appendix was 50 centimeter long, high upward below the liver. This is recorded before. The base of the appendix, the surface anatomy of it, if you draw a line from the umbilicus to the anterior superior iliac spine, the junction of the right third and left 2/3 of this line is the McBurney's point. This is where the base of the appendix lies. So the junction of the lateral 1/3 to the medial 2/3. So the point is nearer to the anterior superior iliac spine rather than nearer to the umbilicus, and this is called the McBurney's point and marks the base of the appendix. And at this point, the surgeon makes his cut. Maximum. Some patients prefer a small cut and some prefer a little large cut, but average cut is 3 centimeters long, passing through this McBurney's point to have access to the appendix. The appendix is part of the intestine that has a mesentery, so it has a mesoappendix, as I showed you here. This is the mesoappendix. In the free border of the mesoappendix is the appendicular artery. This is important to know. And on the appendix itself is the appendicular vein. So the vein is on the appendix itself, but the artery is in the free edge of the mesoappendix. This is an important multiple choice question too. It resembles a bursa in birds called bursa of Fabricius. It has no known function except it's part of the immune system, maybe because of its wall is filled with lymphoid follicles. It has no role in digestion, I mean. The ascending colon, it's shorter than the descending colon. It's 15 centimeters long, ascends anterior to the iliac fascia, iliacus muscle, the iliolumbar ligament, and go upward to pass over the quadratus lumborum muscle, and separated from these by the nerves you can see here. So see the lateral femoral cutaneous nerve, the ilioinguinal nerve, and the iliohypogastric nerves as it goes up. The same thing on the left side, but because the left side is longer and higher, a little higher than the right, so add subcostal nerve and vessels to this. So on the right side, you begin with the iliohypogastric, ilioinguinal, and lateral femoral cutaneous as posterior relations to the ascending colon. On the left side, add to this the subcostal nerve and vessels, because it reaches the left colic flexure is higher than the right colic flexure. Anteriorly to the descending colon, it has the abdominal wall, greater omentum, and coils of intestine. Now, till you reach the right colic flexure, the right colic flexure is on the lower pole of the right kidney. It's less acute than the left side, directed forwards. So you twist the large intestine forwards. The posterior surface becomes anterior, and the anterior becomes posterior. See, as the way you flex it here. And you can notice that with the arrangement of tinea coli. Here, the tinea coli has a single anterior column, but as you can see here in the transverse colon, it has two columns, superior and inferior. These were on the back, and the anterior one became posterior. Now you understand? And then this arrangement will go back to the original arrangement where the anterior single band is present, and posterior, posteromedial and posterolateral bands are present on the descending colon. The right colic flexure has anteromedially the descending part of duodenum and fundus of gallbladder, and this is anteromedial. Anterolaterally, it has the right lobe of liver. So it's hidden behind the liver. It makes an impression on the posterior or the inferior surface of the liver, as we will study in the liver impressions, the impression of the right colic flexure. But remember, please, it's not on the posterior abdominal wall. It's on the lower pole of the right kidney, the case indifferent in the left colic flexure. The transverse colon is 50 centimeters in length, has a narrow lumen, and right end has no mesentery, attached by connective tissue to the second part of duodenum, because the right colic flexure is on the lower pole of kidney. The area just medial to it is on the second part of duodenum, attached to it by connective tissue. And then the transverse colon starts to obtain a mesentery. The mesocolon, the transverse mesocolon. Anterior, it's related to the posterior layer of greater omentum. The greater omentum comes down over the upper surface of the transverse colon and gets attached to it. And if you separate, you can separate both the greater omentum from the transverse colon and from the transverse mesocolon. And this is an approach some surgeons follow when trying to reach to deeper areas in this area, where they dissect or gently separate the greater omentum from the wall of the transverse colon and its mesentery. You can go have access posteriorly. Posteriorly, the colon is related to the second part of duodenum, head of pancreas, upper end of the mesentery, and duodenojejunal flexure of the small intestine. And the mesocolon root itself is attached to the anterior border of the pancreas. The pancreas has a triangular cut section with an anterior border and posterior-superior border, posterior-inferior border. The anterior border has the transverse mesocolon attached to it. Remember this. The left colic flexure is more acute than the right one. It's higher because it's attached to the diaphragm by the phrenico-colic ligament, and it's on the left side of the left kidney. It's not on the kidney, it's on its left side. So the kidney is its right relation, and it makes an impression on the spleen too, because superiorly is the lower part of the spleen and the tail of the pancreas. So remember, the right colic flexure made an impression on the liver. The left colic flexure made an impression on the spleen. Remember this. The descending colon is longer than the right. It's around 25 centimeters long. Descends on the lateral side. As I said before, the same posterior relations, the quadratus lumborum and the iliacus, and with the nerves intervening, but add superiorly the subcostal nerve and vessels. And because the descending colon goes medially as you go down, so it crosses the psoas major muscle with structure on top, which is the ureter, the gonadal vessels, and the genitofemoral nerve. All these are posterior relations to the descending colon. So it's easy. The posterior relations of the descending colon, the same like the posterior relations of the right side, the ascending colon, plus the subcostal nerve and vessels, plus the psoas major with structures on top, the ureter between the genitofemoral nerve deep and the gonadal vessels superficial to it. Okay, of course, anteriorly you have coils of intestine and the anterior abdominal wall. The sigmoid colon, this is a beautiful dissection of the sigmoid colon. See, this is the sigmoid colon elevated here to show you the recess underneath. It's named sigmoid because it obtains an S-shaped course. It goes to the right and may reach the right pelvic wall. Yes, it may reach the right pelvic wall and goes back to the midline. By doing so, it takes a triangular shaped mesentery with it. With the mesentery has two roots, has horizontal and vertical roots. The horizontal crossing the external iliac vessels and the vertical root crossing the internal iliac. But the important thing here for surgeons, that if you introduce your finger in the intersigmoid recess high up to its apex, you will be pressing on the left ureter. So this is a surgical landmark, how to reach the left ureter simply by elevating the sigmoid colon. Introduce your finger in the sigmoid mesocolon, intersigmoid recess and go upwards till its apex and press back. This, now you are on the left ureter. Laterally, it's related to the left external iliac vessels. Laterally, here at this side, obturator nerve, ovary, and lateral pelvic wall. Posteriorly related to the internal iliac vessels, the left ureter, the piriformis, and the sacral plexus as you go down. It ends level of S3 by becoming the rectum, by the way. Inferiorly in males, the urinary bladder, and in females, the uterus. And the tinea coli are the broadest in this part of the intestine, preparing to be a complete layer on the rectum. And the appendices epiploicae are much numerous on the sigmoid colon or the pelvic colon. There is a case called diverticulosis in which it hits the large intestine, where diverticuli formed inside at the size of entry of the blood vessels. So the appendices epiploicae to the outside and these diverticuli to the inside. It's precancerous, and if any patient has diverticulosis, it's recommended to excise the part affected with safety margin of the large intestine. So this affects the large intestine compared to, for example, Crohn's disease, which is an inflammatory bowel disease. It hits any part of the intestine and expresses itself by severe diarrhea and malnutrition because of this diarrhea. The intersigmoid fossa, as I told you now, it has a triangle, two limbs, horizontal limb and vertical limb. The horizontal limb crosses the external iliac vessels, the vertical limb on the internal iliac artery, and it has an apex that is related to the left ureter, the intersigmoid recess. The innervation of the colon differs according to region. Now, the vagi, as we studied before, will supply the GIT until the junction of the right 2/3 and the left 1/3 of the transverse colon. So the effect of vagi ends at this point, at the junction of the right 2/3 and left 1/3. And how it reaches there, of course, remember the vagal trunks, they send celiac branch. A celiac branch passes through the celiac ganglia without relay, intermingles with the aortic plexus, and distributed along the plexus around the superior mesenteric artery to the areas supplied by the artery. And the superior mesenteric effect goes till the junction of the right 2/3 and left 1/3, where the hindgut begins. The superior mesenteric is the artery of the midgut. The inferior mesenteric is the artery of the hindgut. Okay, the sympathetic comes from the celiac and superior mesenteric plexuses through the plexus around the superior mesenteric artery. Here I brought you this plate to show you the aortic plexus. All this is called the aortic plexus. There is a superior hypogastric plexus here, which is cut, and it receives two presacral nerves or hypogastric nerves that come from the inferior hypogastric plexuses on the side of the pelvic wall. They are not shown here, but just to show you that the pelvic splanchnic nerves, the source of the parasympathetic supply to the hindgut, ascends in through these plexuses, through the inferior hypogastric plexus, the presacral nerves, to the superior hypogastric plexus, all this without relay, of course, until it reaches the aortic plexus and then descends along the inferior mesenteric artery with inferior mesenteric plexus. And this is how the parasympathetic supply reaches the rest of the colon. From the junction, from the left colic flexure down, it's supplied by parasympathetic by the pelvic splanchnic nerves. And the sympathetic comes from the the lumbar splanchnic nerves that go to the superior hypogastric plexus and distributed with the plexus around the inferior mesenteric artery. Okay, so this is the supply of the intestine. Remember, there is a difference between its proximal and distal parts, sympathetic and parasympathetic. Of course, the parasympathetic increase motility, secretion, and open sphincters in the GI tract. The opposite happens when stimulating the sympathetic supply. The blood supply, the arterial supply, comes through the superior mesenteric and inferior mesenteric. The superior mesenteric artery originates level with L1 from the abdominal aorta, just inferior to the celiac trunk. It sticks to the inferior part of the celiac trunk. Actually, it comes from very little distance below it. The superior mesenteric first branches, this is multiple choice, is the inferior pancreatico-duodenal to supply the duodenum and the pancreas. Remember this. And then it gives off colic branches, the ileocolic, the right colic, and the middle colic. How do you differentiate these? Especially that in the case of the right colic and ileocolic, the origins may differ between subjects. You look at the direction the artery is headed. If it's going towards the cecum and the terminal ileum, this is the ileocolic branch. If it's going horizontally to the right, this is the right colic branch, especially when you find out that it divides into superior and inferior branches. The middle colic, it's the artery that's going directed towards the right colic flexure. See, this is the middle colic artery. Middle colic, right colic, ileocolic. Now, of course, they must divide into branches. The middle colic divides into left and right branches. The right colic ascending and descending branches. You don't have to learn these by heart. It's logic. And the ileocolic, named ileocolic because it supplies the terminal ileum and the cecum. So it gives a colic branch and an ileal branch or branches. Okay, and the colic or cecal branch divides into anterior and posterior branches to cover the surfaces of the cecum. The posterior branch, the posterior cecal branch, is the one that gives the appendicular artery that supplies the appendix and runs in the free border of the mesoappendix. As you see here, this is the appendix. This is the appendicular artery. Of course, the mesoappendix is dissected, and you can see obviously here the anterior cecal branches and the posterior cecal branches. See that? And this is the terminal ileum. This is the cecum reflected. This is the posteromedial side of the cecum. I hope you're oriented now because this is a close-up. So this is the ileum, ileocecal junction. This is the anterior cecal branch of the colic branch of the ileocolic. These are the posterior cecal branches of the cecal branch of the ileocolic, and this is the appendicular artery. It's beautifully dissected here to show you. See, it's very obvious. This is the appendicular artery in the free margin of the appendix. Remember, the artery is in, and trust me, you will get this question. The artery is in the free margin because this is what you do in appendectomy. You clamp the artery. So you go to the mesoappendix and you pierce it and clamp the artery in the free edge, while the vein is on the appendix itself. Okay, last thing to talk about is the inferior mesenteric artery. Originates around 3 centimeters above the bifurcation of the aorta. First anterior, then to the left of the aorta, as you can see here, and gives, you can call it in two ways now, the branches of the inferior mesenteric. Upper branches you can call colic branches, left colic branches, and the lower branches are sigmoid branches. Or you can call the upper branches the upper left colic and the lower branches lower left colic. So if you use the term upper left colic, use lower left colic for the sigmoid branches. If you use the term left colic branches, use sigmoid or pelvic colon branches of the inferior mesenteric. After giving the sigmoid numerous branches, as you can see here, and left colic branches here that divides into ascending and descending branches, it continues in the pelvis as the superior rectal that will supply the rectum down to the level of the anal canal. We will study this in the pelvic and perineum. But note that see the branches of the main arteries supplying the intestine, they anastomose and form a marginal artery. See that? The marginal artery. It's well developed superiorly and on the left side. Of course, it can get complete circle on the right side, but this is the marginal artery. They will ask you a tricky question about which marginal artery is intraperitoneal, which marginal artery is retroperitoneal. This is easy. The marginal artery at the descending colon part is retroperitoneal because the colon is retroperitoneal. The marginal artery in the sigmoid colon area is intraperitoneal because it's inside the sigmoid mesocolon. The same applies to the transverse colon. The marginal artery is intraperitoneal, while the marginal artery on the right side is retroperitoneal. It's a tricky question. Instead of asking you about the direct branches of the vessels supplying the intestine, they ask you about the marginal artery that is formed by the anastomosis of the different branches that supply the large intestine. Now, veins follow the arteries, and veins are outside the arteries. Veins are outside the arteries means that the inferior mesenteric vein is on the left side of the inferior mesenteric artery. The superior mesenteric vein is on the right side of the superior mesenteric artery. You know what I mean? So veins on the outside and arteries on the inside. Remember this. Don't use lateral and medial, you will get confused. The inferior mesenteric to the left side of the inferior mesenteric artery. The superior mesenteric vein is on the right side of the superior mesenteric artery. Of course, you know the story of the superior mesenteric. It will join the splenic and eventually form the portal vein, while the inferior mesenteric vein, as it go up, remember it raises the paraduodenal fold, remember that, and then opens either in the splenic, either in the portal, either or in the superior mesenteric. So you may find different openings among individuals. Anyway, the blood in the inferior mesenteric eventually will go to the portal vein, as we learned before, because any blood coming from the intestine must pass through the liver first before emptied into the general circulation. Okay, this is the basic anatomy of the large intestine, its blood and nerve supply, and its arrangement. I hope you got the maximum benefit from this lecture, and thank you very much for watching.